There's two major populations that would suffer from joint diseases. That would be the younger population and the older population. The younger population would be characterized by mostly injuries, trauma, whatever origin, sports, work, hiking, recreational, everything that is concerning physical activity of the younger age. And these pathology would be characterized mostly by meniscal problems, ligament problems, and so on. The other large group of patients that would suffer from joint diseases would be the elderly patients. They would suffer from the most common joint disease, that is a degenerative primary osteoarthritis, with all that it concerns. This is one of the fields that occupies us in terms of surgery. This is one of the most prevalent diseases in the world in white Caucasian people. This is the field that engages a lot of surgery in the field of arthroplasty, people who need to have joint replacement and treatments concerning their joint disease. And in the middle, there's a less numerous number of patients that would suffer from various other diseases. It used to be very traditional, joint replacement, knee and hip arthroplasty. It has become, as I said, very prevalent because people would not give up their will to lead an active, social, physical, and otherwise recreational life. So it has become a demand of the first class because of the major trends that would influence this would be, first of all, the longevity, the extension of the longevity of people. The average life expectancy is rising, and accordingly also the way people see themselves inserted in daily living. They would not want to give up their activities. It doesn't have to be anything athletic. It could be something concerning family, friends, insertion in social activities, of course sports and recreation and so forth. So if that provides a solution, they would go for it, and that's what inflates the number of surgery. There is an article that expects the rise of total knee replacement in the United States up to the year 2030 in a number of 600%. That would be 6 times more than it is. So if in the past we would like people to have joint replacement at the age of 65 and above, today it's almost irrelevant. We do it when a patient feels like his life quality has reduced to justify joint replacement. So you can have it at the age of 55 and 57 and 62, and so on and on. Everything is according to personal limitation. So there's no number that we limit patient by. We are regarding their needs and their limitation, and that would be the indication for surgery. The average age for people who are undergoing arthroplasty at the beginning of the 6th decade to the end of the 8th decade of life. The average survivorship of an implant is about 18 years today, 18 years average, with various differences between implants, between patients, and between basic pathology that requires the surgery. But that was the rationale of trying to operate patient at the age of 65, considering that you have about 15 to 18 years to live with the implant, and then if the implant is loosened, and this is what happens naturally to an implant, then you'd have to go a second surgery. So generally, in order to avoid second surgery, which is the revision, which is quite a big operation, we would rather people to have it at 65. But it's not like this anymore. First of all, the option for a bad knee is knee replacement. Now, within the field of knee replacement, there's a couple of versions. There is a version for the younger or the most specific pathologies that are not in the big cohort of primary osteoarthritis. This is one version is what we call the unicondylar hemiarthroplasty. We replaced just part of the damaged knee. So it's a partial knee replacement. There is an implant specified for partial knee replacement. Then there is the total knee replacement, which is the common operation. Within the field of knee implants, of course, there's variations. Everything is concerned to the concept, to the company, to the developer, to the scientific group that behind the development of an implant. But the basic outliers and the guidelines and the design of a total knee replacement is following generally the same rules. The implants themselves are hard to distinguish. It's very difficult to say this company has the best one and the other one is the less. Most of the implants would reproduce the results of the other. It takes about 2 hours with all the preparations and the anesthesia and the covering and sterilization and prepping and drepping and all the things around. It's like every surgery. It is considered to be a big operation in any version. It doesn't matter what kind of tools you use, or if you do it with a 3D implant, or if you do it with a robotic arm, if you do it conventionally. However technique you prefer to use, it's considered to be a big operation, and it needs to be regarded so and delivered so to the patient. They won't be surprised for the magnitude of surgery that does not fit what they expected. Oh yes, and even better. Of course, everything is a function of time and rehabilitation. It doesn't happen immediately. We talk about years to follow. We're having arthroplasty to patients to use it for many years. The immediate postoperative period would be, of course, difficult, but it's like every surgery, and it's a surgical act. So it has a beginning, a middle, and an end. It's not a disease, it's surgery. By the time you recover, you finished your rehabilitation and everything is okay, you probably can do twice as better as before. First of all, you should remember that the operation, the knee, is replaced in order to use it. Many people have this psychological block that they think, now I have a new toy in my knee, I have to protect it. Well, no, you have to use it. That's why we do it. That's one thing they have to remember. Second, they have to remember that it's an implant. It's not God's made, it's our made. So there may be days where you feel better, days where you feel worse, but in general, you'd be about much better than before.